Pure vegetarian diet, evidence-based clinical analysis. Good morning, colleagues. I'm Dr. Ashutosh Mishra from Panacea Hospital, Varanasi. Today, I want to discuss something that often gets dismissed in clinical practice, plant-based nutrition as evidence-based medicine. For years, we've relied on pharmaceutical interventions. But the evidence increasingly suggests that dietary modification, specifically appropriately planned vegetarian and vegan diets, deserves a place as first-line therapy in our cardio-metabolic disease management. Over the next 15 minutes, we'll examine the science, the mechanisms, and most importantly, the pitfalls. Because as Socrates wisely said, I know one thing that I know nothing. So let's approach this with scientific humility. Why this matters? India's cardio-metabolic crisis. Let's begin with the Indian context because this is urgent. India faces a converging epidemic. Diabetes prevalence exceeds 11%. That's over 100 million people. Premature cardiovascular disease is our leading mortality driver. Chronic kidney disease affects 17% of adults, nearly 150 million people. And urban obesity has tripled. Now, what's driving this? Processed foods, refined carbohydrates, sedentary lifestyles. We're eating ourselves sick. But here's the opportunity. Plant-based nutrition offers a scalable, low-cost, evidence-based intervention. It complements our medications, metformin, GLP-1 agonists, ACE inhibitors, statins, without adding medication burden. This is precision medicine. For Cardiabcon and Cardiabcon audiences, this is game-changing. We can now recommend dietary modification as Class 2A evidence-based therapy. Defining the dietary spectrum first, let's define what we're talking about because vegetarian means different things. We have 4 categories. Pure vegan, no animal products whatsoever, meat, dairy, eggs, honey, nothing. Lacto-vegetarian, dairy allowed, milk, yogurt, paneer, ghee, most common in India. Ovo-vegetarian, eggs allowed, no dairy. Less common here but rising among younger populations. Lacto-ovo, both dairy and eggs permitted. Most nutritionally flexible, lowest deficiency risk. This distinction matters clinically. Our lacto-vegetarian eating dahi and paneer faces different micronutrient challenges than a strict vegan. Today, I'll address all patterns but emphasize appropriately planned is the operative phrase. Haphazard vegetarianism will fail. Global prevalence and economic reality. The demographics are striking. Globally, 40% identify as vegetarian. That's 3 billion people. Here in India, Gujarat and Rajasthan exceed 60% vegetarian populations. The motivations are cultural, religious, ethical. The economic data is equally compelling. The global plant-based market reached $74.2 billion by 2027 with 11.9% annual growth. Generation Z shows 25% vegetarian adoption versus 5% in baby boomers. This is a generational shift. And the environmental argument is undeniable. Plant-based diets reduce carbon footprint by up to 73%. But most critically for us as physicians, the health outcomes. Vegetarians show 29% reduced cardiovascular disease risk, 22% reduced type 2 diabetes risk. These aren't marginal benefits. Macronutrient architecture, the foundation. Let's discuss the fundamental macronutrient differences. Plant-based diets shift us toward complex carbohydrates, resistant starch, viscous fiber, slowly digestible carbs from legumes and whole grains. This means sustained glucose release, improved glycemic control. The glycemic index difference is profound. Second, plant proteins and fiber. Yes, plant proteins have lower digestibility, about 70 to 85% versus 95 to 100% for animal proteins. But plant-based diets provide abundant fermentable fiber, feeding beneficial microbiota. You also get phytosterols and polyphenols, powerful anti-inflammatory compounds absent from meat. Third, healthy fats, predominantly unsaturated fatty acids from nuts, seeds, avocados, plant oils, dramatically lower saturated fat, zero dietary cholesterol. Here's the critical mechanistic point. Lower methionine and fewer advanced glycation end products, AGs reduce oxidative stress and inflammatory signaling. This is particularly relevant for diabetes and CKD management. In essence, you are reducing the inflammatory substrate driving cardiometabolic disease. Lipid profile randomized evidence. Now to what most interests cardiologists, lipid profiles. Meta-analyses pooling over 8,000 participants from randomized controlled trials show consistent reductions. Total cholesterol down 13 milligrams, DLDL cholesterol down 12 milligrams, DL clinically relevant non-HDL cholesterol, 14% reduction ApoB particles. Parallel reductions, the magnitude, this is equivalent to low-dose statin monotherapy achieved through diet alone. No side effects, no muscle pain, no liver enzyme elevation. But we're not just talking LDL anymore. Advanced lipoprotein modification, the sophisticated cardiologist should understand beyond LDL. Small dense LDL particles, the truly atherogenic subtype, decrease 15 to 20% on plant-based diets. These particles are the real villains in atherosclerosis. Lipoprotein, traditionally considered genetically fixed, right? But plant-based interventions show 10 to 15% reduction in LP, likely through reduced oxidative modification of apolipoprotein. This is residual cardiovascular risk many patients still carry despite statin therapy. Inflammatory lipoproteins, oxidized LDL decreases up to 30%. Myeloperoxidase modified lipoproteins also decline. We're improving functional lipoprotein quality, not just concentration. HDL functionality, enhanced HDL love capacity, 5 to 10% increase in paraoxonase 1 activity, the enzyme responsible for HDL's anti-inflammatory properties. We are achieving pleiotropic vascular benefits. This is sophisticated lipid management through food. Blood pressure and vascular function, blood pressure reductions are clinically significant. Vegetarians show 5 to 7 millimeters of mercury systolic BP reduction and 3 to 5 millimeters of mercury diastolic reduction. That's equivalent to a single antihypertensive agent without side effects. The mechanisms are elegant. Higher potassium intake, 3,500 to 4,500 milligrams daily promotes renal sodium excretion. Increased L-arginine availability enhances nitric oxide mediated vasodilation. Lower saturated fat reduces inflammatory eicosanoid production. Reduced uric acid decreases oxidative vascular damage. Additionally, pulse wave velocity, a marker of arterial stiffness, improves 15%. For hypertension management, this is now class 2A evidence. We should counsel patients on plant-based diets before escalating antihypertensive therapy. Type 2 diabetes glycemic control for endocrinologists and internists. The diabetes data is compelling. Vegetarian and vegan diets produce minus 0.4% absolute HbA1c reduction, clinically significant, reducing microvascular complications by 15 to 20% minus 0. 9 kilograms MBMI decrease, important for weight-driven glucose control, minus 20 to 30% lower type 2 diabetes incidence in high-risk populations independent of BMI and physical activity. The mechanisms are multifaceted. First, fiber and resistant starch. Slow gastric emptying 20 to 30%, attenuate postprandial glucose spikes, improve GLP-1 and GP secretion. Second, enhanced insulin sensitivity. Lower saturated fat and reduced ectopic fat position in liver and muscle, enhance insulin receptor signaling, up to 40% improvement. Third, microbiome modulation. Plant fiber promotes beneficial Akkermansia and Bifidobacterium, 50% increase. This improves intestinal barrier integrity, reduces systemic endotoxemia, decreases insulin resistance. So when patients ask, doctor, can I avoid metformin? The answer is, diet is powerful adjunctive therapy. Metabolic syndrome and neophyte metabolic syndrome is rampant in India. Plant-based diets reduce its prevalence up to 30%. We see improvements in all components. Waist circumference reduction of 3 to 5 centimeters. Triglyceride lowering 10 to 15%. Fasting glucose improvement, 25% improvement in insulin sensitivity. Modest HDL increase. More exciting is NAFLD, non-alcoholic fatty liver disease, which is epidemic in our diabetic populations. Plant-dominant diets reduce hepatic content 20 to 40% on MRI spectroscopy, lower aminotransferases 15 to 25 UL, improve fibrosis markers like 5B4 and APRI scores, and reduce hepatic inflammatory cytokines like TNF-alpha and IL-6. This is evidence for dietary intervention as adjunctive NAFLD management alongside weight loss and insulin sensitizers. For patients with metabolic syndrome and fatty liver, plant-based nutrition is therapeutic. Cardiovascular events and mortality, the ultimate outcome data. Does this prevent heart attacks and strokes? Primary prevention. Large prospective cohorts. The Adventist Health Study 2, EPIC Oxford, with over 70,000 participants and 5-year follow-up show 20 to 25% lower cardiovascular disease incidence in vegetarians versus matched omnivores. This is independent of BMI, smoking, and exercise. Secondary prevention. In patients with established CVD, plant-based diets reduce composite cardiovascular events, myocardial infarction, stroke, revascularization, cardiovascular death by approximately 15% relative risk reduction. Mortality benefit. Cardiovascular mortality is reduced 12 to 18% with greater benefit in highly adherent individuals consuming whole food plant-based patterns versus processed vegetarian diets. Here's the critical caveat: quality matters more than label. Ultra-processed vegetarian diets, refined carbohydrates, fried foods, added sugars show no cardiovascular advantage. In fact, high ultra-processed food intake confers 14% higher all-cause mortality risk. Whole food plant-based patterns are protective. Junk vegetarian patterns are harmful. Coronary plaque regression. Imaging evidence. For skeptical cardiologists, the angiographic data is impressive. Astonish's landmark trial, a 12-month intensive plant-based intervention showed reduced stenosis diameter for 5% absolute stenosis reduction in 82% of patients, while 53% of controls showed progression. Esselstyn series. Angiographic improvement in compliant patients combined with aggressive lipid lowering. Intravascular ultrasound documents 15 to 20% reduction in plaque volume and increased lumen diameter. Functional benefits. Flow-mediated dilation FMD improves 2.5% within 8 to 12 weeks. Enhanced endothelial function, increased HDL cholesterol efflux capacity, reduced inflammatory biomarkers. So this isn't just risk factor modification. We're seeing actual plaque regression. That's extraordinary for a dietary intervention. Chronic kidney disease, GFR preservation. For nephrologists, plant-based diets represent a breakthrough in CKD management. GFR decline. Meta-analyses with over 1,500 CKD patients show that vegetarian low-protein diet 0.6 to 0.8 gkg day slow GFR decline from the typical to 3 milliliters min 1.7 square meters per year down to only 0.5 to 1 milliliter min per year. Proteinuria reduction. Albumin excretion decreases 20-30% when plant protein replaces animal protein independent of total protein quantity. The quality matters. Synergy with RAS blockade. Combined ACE inhibitor ARB therapy plus plant-based diet shows additive renoprotective effects, reducing ESRD risk by 35%. We are delaying dialysis initiation by 2 to 5 years in compliant patients. Mineral bone disease. Plant phosphorus phytate bound has only 40 to 50% bioavailability versus 80 to 100% from animal sources. So serum phosphate decreases 0.5 to 0.8 milligrams DL. PTH levels 30 to 40% lower. Vascular calcification 50% reduction. Uremic toxins. Plant predominant diets shift the microbiota, reducing proteolytic bacteria that generate indoxyl sulfate and p-cre sulfate. Circulating protein-bound uremic toxins decrease 40 to 60%, correlating with slower CKD progression and 25 to 35% lower cardiovascular mortality in dialysis patients. This is renal protective medicine. Weight management and satiety. Weight loss without calorie counting. Is that real? Yes. Plant-based whole foods provide 30 to 40% fewer calories per volume due to high water and fiber content. Viscous fiber delays gastric emptying, increases meal-induced thermogenesis, stimulates satiety hormones, 2 to 25% increase in CCK, GLP-1, PIY. Long-term data, prospective cohorts link plant-based eating with 1.5 to 2.0 kilograms m lower BMI, independent of self-reported caloric intake. Meta-analyses show vegetarian diets produce 3 to 5 kilograms greater weight reduction versus conventional calorie-restricted omnivorous diets over 12 to 18 months without explicit calorie counting. For our obese diabetic patients struggling with adherence, this is powerful. Micronutrient strengths, the nutritional advantages are real. Vitamin C, plant-based diets provide 150 to 300 milligrams daily, 2 to 3 times higher than typical omnivore intake. This supports collagen synthesis, immune function, and critically iron absorption enhancement. Folate. Green leafy vegetables, legumes, fortified grains deliver 400 to 600 micrograms daily, essential for homocysteine metabolism, DNA synthesis, neural tube defect prevention. Magnesium and potassium, 350 to 450 milligrams magnesium and 3500 to 4500 milligrams potassium daily support cardiovascular health through enhanced nitric oxide production, reduced arrhythmia risk, improved insulin sensitivity. Phytochemical diversity. Over 5,000 phytochemicals identified in plants, polyphenols, carotenoids, glucosinolates. These are absent from animal foods and provide antioxidant, anti-inflammatory and epigenetic benefits. So far, this looks excellent. The critical downsides: protein quality. Now, colleagues, full transparency. Plant-based diets have real significant pitfalls. Protein digestibility. Plant proteins show 70 to 85% digestibility versus 95-100% for animal proteins. Cell wall structure protease inhibitors, tannin binding reduce availability. You need 15 to 20% higher absolute protein intake. Amino acid profile. Most plant proteins lack adequate lysine, methionine, or both. Legumes are methionine deficient. Grains lack lysine. Proper complementary recombining achieves 80 to 90% bioavailability but requires knowledge. Scores. Digestible indispensable amino acid scores: chickpeas 0.83, 0.67, wheat 0.0, fall short of animal proteins, eggs 1.13, whey 1.09, chicken 1.00. Sarcopenia risk. Older adults and CKD patients risk protein energy wasting without strategic legume cereal pairing and potentially higher total protein targets 1.2 to 1.4 GKJ. This isn't ignorable. We'll see consequences if we're not strategic. The critical downsides: vitamin B12 deficiency. Vitamin B12 is synthesized exclusively by bacteria, found naturally only in animal products. Fermented plant foods, they contain analogs with minimal bioactivity. Here's the harsh reality: minus 40 to 60% of vegans show serum B12 less than 200 pmol. Minus 60 to 80% have elevated methylmalonic acid, a marker of deficiency. Minus 50 to 70% have elevated homocysteine deficiency onset. Typically 2 to 3 years post-adoption, the clinical consequences are severe. Hematologic, megaloblastic anemia, pancytopenia, neurologic, subacute combined degeneration, peripheral neuropathy, cognitive impairment, potentially irreversible vascular hyperhomocysteinemia driven, endothelial dysfunction, accelerated atherosclerosis. This is not marginal. Neurologic damage from prolonged B12 deficiency persists despite later repletion. Mandatory supplementation: 1000 to 2000 micrograms weekly or 50 to 100 micrograms daily. Target serum B12 250 to 300 pmol with supplementation. Monitor methylmalonic acid annually. B12 supplementation is non-negotiable for strict vegans. The critical downsides: iron bioavailability, iron absorption disparity is substantial. Non-heme iron from plants 2 to 3% absorption. Heme iron from meat 15 to 35%. Phytates, polyphenols, tea, coffee, and calcium competitively inhibit non-heme iron uptake. High-risk populations: menstruating women 18 milligrams day iron requirement. 2 to 3 times higher iron deficiency, anemia prevalence on plant-based diets due to monthly blood loss combined with low bioavailable intake. CKD patients: chronic inflammation and uremic milieu impair iron utilization. Vegetarian CKD patients require aggressive screening. Mitigation strategies: consume vitamin C rich foods with iron sources. 100 milligrams vitamin C increases absorption 3 to 4 fold. Avoid tea or coffee with meals. Ferritin monitoring every 6 months. Target 30 mg/ml. Consider ferrous sulfate 65 milligrams, elemental iron daily supplementation. Iron deficiency is preventable with knowledge. The critical downsides: zinc, iodine, selenium, 3 trace mineral concerns. Zinc, plant diets provide 43 to 54% lower zinc as phytate binding reduces absorption to 5 to 50% versus 70% from animal sources. Manifests as impaired cellular immunity, delayed wound healing, taste dysfunction, alopecia. Iodine. Without dairy, fish or seaweed, vegans frequently fall below 150 micrograms day requirement. Risk: hypothyroidism, worsening lipid profiles and CVD risk, fetal neurodevelopment impairment during pregnancy. Selenium. Soil selenium content varies dramatically by region. Plant-only diets may provide inadequate amounts, 55 micrograms day requirement. Affects thyroid hormone metabolism and antioxidant enzyme function. For CKD patients on ACE inhibitors or ARBs, urinary zinc losses exacerbate deficiency. The annual zinc monitoring is recommended. The critical downsides: bone health and fracture risk. Bone health is often overlooked. Absorption challenges: oxalate-rich greens, spinach, chard show less than 5% calcium absorption. Low oxalate greens, kale, broccoli show 50 to 60%. Phytates in legumes and whole grains reduce absorption 20 to 60%. Cow's milk 30 to 32%, not dramatically higher fracture risk data. Long-term vegans show 0.3 to 0.8 SD lower BMDT scores. EP Oxford 30% hip fracture risk in vegans. Systematic review: 15% increased total fracture risk in vegetarians, vegans. Postmenopausal vegan women are highly vulnerable. Contributing factors: suboptimal calcium intake, absorption, lower BMI. Protective in some contexts, detrimental for bone. Reduced estrogen levels, vitamin inadequacy, lower protein intake, acid-base imbalance. Recommendations: target 100 to 1200 milligrams day calcium from fortified plant milks, tofu, low oxalate greens. Supplementation often necessary. DX scans baseline, then every 3 to 5 years. Ensure adequate vitamin D 600 to 800 IU daily and vitamin K2. This requires proactive management. The critical downsides: hyperkalemia in advanced CKD. Here's a life-threatening concern many overlook. Bananas 358 milligrams potassium per 100 g. Spinach cooked 558 milligrams. Lentils 369 milligrams. Potatoes baked 535 milligrams. Normal serum potassium 3.5 to 5.0 Zki. Hyperkalemia K plus greater than 5 ml affects up to 50% of advanced CKD patients. In CKD stages 4 to 5 with EGFR less than 30 milliliters min per 1.73 square meters, high dietary potassium combined with ACE inhibitors, ARBs or aldosterone antagonists frequently precipitates dangerous hyperkalemia K plus 6.0 MEQL. This causes P waves, widened QRS complexes, ventricular arrhythmia, sudden cardiac death. Mortality risk is 2 to 3 times higher with severe hyperkalemia episodes. Management: leaching techniques, soaking, discarding water, reduce potassium 30 to 50%. Portion control is essential. Neopotassium binders like patyroma and sodium zirconium cyclosilicate decrease K plus by 0.5 to 1.0 MEQL within 48 hours. These enable safer plant-based eating patterns in CKD. For advanced CKD, plant-based diets require individualized dietitian guidance and potassium monitoring. Gastrointestinal tolerance and fiber fermentation jumping from 15 to 40 to 60 g. Daily fiber intake triggers excessive colonic fermentation, 2 to 4 liters of gas daily. Bloating affects 40 to 60% of patients. Cramping, osmotic diarrhea. FODMAP challenge: legumes are high in galacto-oligosaccharides 1 to 3 g per 100 g dry weight. Onions, garlic rich in fructans 5 to 15% dry weight. Up to 75% of IBS patients report symptom relief on low FODMAP diets. Adaptation timeline: the gut microbiome requires 8 to 12 weeks for optimal adaptation. Premature dietary shifts lead to 30 to 50% patient dropout due to unmanaged GI distress. Strategy: start with 5 G day fiber increments weekly. Pressure cook legumes greater than 30 minutes reduces oligosaccharides 50 to 70%. Consider low FODMAP plant foods initially. Rice, quinoa, carrots, zucchini for 4 to 6 weeks. Add probiotics, lactobacillus, bifidobacterium. Cautiously, improvements in GI discomfort within 2 to 4 weeks. We must titrate, not shock the system. Slide 23. The ultra-processed vegetarian trap at duration 1 minute. Quality trumps labels completely. Self-identified vegetarians consuming greater than 50% of calories from ultra-processed foods often include refined grains, white rice, past glycemic index 70 to 80, added sugars, fried snacks, pakoras, samosas loaded with trans fats, ultra-processed meat analogs with greater than 500 milligrams sodium per serving. Recent cohort analysis, 14% higher all-cause mortality risk for those with high ultra-processed food intake on plant-based diets. Conversely, high-quality plant-based diet indices emphasizing whole, minimally processed foods, legumes, nuts, seeds, fruits, vegetables consistently show 25 to 30% lower type 2 diabetes risk, 20 to 25% lower cardiovascular disease incidence, 10 to 15% LDL reduction, 5 to 10% fasting glucose reduction, minus 20% CRP reduction. The principal whole food plant-based equals protective, junk vegetarian is harmful. This cannot be emphasized enough. Pharmacotherapy interactions, plant-based diets enhance medications. Understanding synergies is critical. SGLT2 inhibitors, GLP-1 agonists are AS blockers. Plant-based diets amplify their effects via insulin sensitivity, reduced albuminuria, weight loss, additional 0.5 to 1% HbA1c reductions for type 2 diabetes, additional 5 to 10 millimeters of mercury systolic BP reductions. Up to 50% of insulin or sulfonylurea patients may reduce or cease medication within 12 to 18 months. This is not a reason to avoid plant-based diets. It's a reason to monitor carefully and adjust medications. Statin interactions. Plant-based diets lower LDL cholesterol 15 to 20%, potentially enabling 25 to 50% statin dosage reduction. Atorvastatin 10 milligrams instead of 20 milligrams with diet. Warfarin interactions. High variable vitamin K from leafy greens, spinach 145 micrograms cup, kale 115 micrograms cup can antagonize warfarin. Consistent daily vitamin K intake and frequent INR monitoring, initially 2 to 3 times weekly, then at least weekly or bi-weekly are crucial. Warfarin dosage may require 10 to 20% initial increase. Novel oral anticoagulants like apixaban and rivaroxaban unaffected. Critical point. Significant dietary shifts require proactive medication adjustment, weekly follow-up for the first 12 months to prevent hypoglycemia, hypotension or INR swings. As a biomarker monitoring protocol, duration 1 minute, aggressive monitoring prevents deficiency complications and builds patient confidence in sustainability. Baseline assessment before dietary transition, vitamin B12 or methylmalonic acid, ferritin, TIBC, serum iron 25 or vitamin D, serum zinc, folate, homocysteine, FGF23, serum phosphate, complete lipid panel, ApoB, HbA1c, fasting glucose, ACRP, EGFR, urine ACR follow-up schedule. B12 homocysteine annually, iron ferret in every 6 months, vitamined. Seasonally, FGF23 phosphate every 6 to 12 months in CKD, lipids HbA1c every 3 to 6 months, initially DACA, bone density every 3 to 5 years, earlier for vegans. Over 40 clinical pearl. Aggressive first-year monitoring prevents complications and builds patient confidence. Slide 26. Summary evidence-based clinical integration. Let me summarize the clinical integration. Point 1. Appropriately planned equals effective and safe. Vegetarian and vegan diets represent class 2 evidence-based interventions for hypertension, dyslipidemia, type 2 diabetes, and early-stage CKD when coupled with mandatory supplementation, B12, vitamin D3, iron, zinc, and biomarker monitoring. Point 2. Quality over labels. Whole food plant-based patterns confer cardio-metabolic benefits. Ultra-processed junk vegetarian diets negate advantages. Emphasize legumes, whole grains, nuts, seeds, vegetables, fruits while minimizing refined carbohydrates. Call to action for Cardiabcon and Cardiabcon. Integrate evidence-based dietary counseling into routine nephrology and cardiology practice. Establish hospital dietitian resources. Educate trainees on nutrition as precision medicine. synergize dietary and pharmacological therapies for optimal outcomes. We stand at a remarkable inflection point. Dietary modification, finally backed by robust evidence, can become first-line therapy. But appropriately planned is non-negotiable. Half measures will fail. As physicians, our responsibility is to provide evidence-based guidance, monitor diligently, and adjust medications as needed. This is the future of preventive cardio-metabolic medicine. Closing remarks, I return to Socrates. I know one thing that I know nothing. The evidence overwhelmingly supports plant-based nutrition as evidence-based medicine. The pitfalls, B12 deficiency, bone health, trace minerals, GI tolerance are real but manageable with knowledge. Our patients deserve both the power of dietary medicine and the safety of informed supplementation and monitoring. Thank you.